Matthew Holt, THCB Spotlight on the HIMSS floor. I'm here with Michael Gould. Michael is the AVP of Interoperability at a company called ZeOmega, best known for, ZeOmega, well known for that sort of population health management suite sold to payers. But Michael does some other stuff. So, Michael, we're going to start off with what the hell ZeOmega does, and then you're going to tell me after that what the interoperability part is, and then we'll ask you a bit more about that. So, number one, what does ZeOmega do?
So ZeOmega serves utilization management and care management needs for payers with its flagship product line called Jiva. And more recently, in 2016, with the acquisition of the Health Unity company, it's moved from health information exchange into interoperability, serving the needs of organizations, both payers and providers, that want to exchange information in support of patient access, payer-to-payer exchange, and more recently, with the new NPRM from CMS, burden reduction of prior authorization processes, all done with standard FHIR APIs.
Okay, so that's the part of the company that you're in
Yes.
charge of. So let's talk a bit about that problem, because we've had on the Jiva / original ZeOmega side, we've had utilization management to review patient population health for a long time. It's still ongoing, but obviously there are changes in the way that data has been moving around healthcare in the last number of years. RNC has been particularly active. Da Vinci is obviously part of that sort of on the health plan side, it's part of that wider effort. So what does the new set of things you're rolling out in utilization management mean in practical terms for the poor SAP at the health plan or the provider who has to sit there and actually see, patient Matthew Holt walks in, he or she wants this procedure, what the hell do we do next? What's that actual workflow change going to be with your new product set?
So by utilizing standard FHIR APIs for burden reduction, we can find out if a prior auth is needed in the first place. Today, providers don't always know for certain whether a prior auth is required, and the energy wasted on prior auths that are not needed, we can eliminate that with the first step in our burden reduction stack. In the second stack, we automate and codify commercially available medical guidelines that are used by payers and providers to establish medical necessity and also to evaluate against payer requirements for making a determination that provides an authorization. And the third part has to do with the actual request and response from the request from the provider and the response from the payer to get an authorization done, in some cases in real time, and in other cases where the burden has been removed with automation, to allow the medical review that's necessary, the expert medical review that's necessary for complicated cases.
Okay, so that presumably now is a lot of phone time requests of all people,
Yes.
the payers sitting there who are thumbing through a PDF saying, yes, I need this chart, I need this image, I need this test, I need whatever, or I can say yes. So you're automating as much as possible that.
A lot of the delays that have been introduced are some of the reasons that prior auth has been cited as a problem in healthcare.
I mean, we've heard a lot
by
about
eliminating those delays and the inefficiencies associated with them, we can do better.
We've heard a lot in recent days and weeks and months about either automated turn down of requests from certain health plans, and also delays certainly in Medicare Advantage, and that's going to get heat.
And we have checkpoints in our process that can prevent that.
Yeah. Okay. So let's tell me about ZeOmega bought Health in a while back, but I mean, there's two what look on the surface being relatively separate product lines. One serving, providers and payers. One serving more the payer side. What's the logic in a company buying those in one company buying the other, and then now you came in later. You weren't there at the time, so you can throw the previous people under the bus. How did it work?
So, the Jiva product was implemented in times before modern APIs were really adopted. It was a solution primarily for payers to communicate and do care management and utilization management functions. That included prior auths. But the advantage by bringing on the Health Unity line is that it can move to standard FHIR APIs that are essentially agnostic to the EMRs on the provider side. So our Health Unity line can integrate with smart apps, FHIR smart apps, smart on FHIR apps, and on the payer side now is not limited to just proprietary integrations with Jiva, but can integrate with other utilization management solutions, so that Health Unity is more of a standalone product. Although we would certainly, being a part of ZeOmega, like to see you use Jiva.
All right, very good. All right, so you mentioned ZeOmega's been around 20 years. You're relatively recently there, but let's just do some basic numbers. Still a private company?
Yes, sir.
How much investment's gone in? When was the last investment went in? And is now money coming out the other end? Because this is...
Yeah, I'm sorry, I don't have the data on investment and coming out recently. I'm gonna claim the new guy card on that one.
Okay, but can I assume the company is that money is coming out and not going in at the moment in terms of profitability? Okay.
Definitely profitability.
This is not necessarily a common thing amongst the show floor here or digital health at the moment. That's good.
But I can tell you that we have somewhere between 40 and 50 million covered lives.
Yeah.
I'm going to ballpark our revenue somewhere in the 50 million range.
Yep.
I'm not.
Okay.
I'd have to fact check
Good
that
enough.
one.
And then give me a sense of current typical customers for the original ZeOmega Jiva product, and then where you're anticipating going with the new product set.
Right. So our main customer base are payers and payviders. So those that combine provider care.
Can you give me a name or two, please?
So one of our companies that we have a long-standing relationship with is AmeriHealth Caritas.
Yep.
And in 2022, we saw an increase of new customers, about 23%. CCS and HealPros are examples there.
Okay.
We saw over 50% of our customers expand their product lines to some of our newer products for social care and quality. And we've seen a number of important customers renew contracts in the last year, among them being Blue Cross and Blue Shield plans, and our new engagements in California among plans there with unique requirements that serve all the California requirements.
And
residents.
What about the cross-sell between the two lines that we've been discussing, the original Jiva and the...
Absolutely. So we've now seen renewed interest with the December 2022 new proposed rule from CMS for improving prior authorizations. And that's led to several RFPs and several near closed deals, a few closed deals, and now we're starting our first implementations that will go live in the coming months.
You can start showing some case studies saying this stuff actually works and makes a difference.
Yeah. It's amazing that within months of a requirement coming out, how the market has responded.
Sure.
And that that goes to the clarity of regulators deriving regulation from from industry.
Well, I think there's that, and also
makes it feasible and realistic.
An acknowledgement that we've all eventually got to do something about the big time mess that is that relationship between payers and providers, and something's going to happen. And I think we've all sat around, those of us who've used the healthcare system at any stage have seen a fair amount of problems in sort of all kinds of basic payment provision. I've written about this stuff on the ACB and elsewhere. I'm sure everyone listening has had enough of their own issues going, why the hell is this stuff so stupid and why can't we fix it? And so you're
the exciting part is now we're able to fix it. We've got the right triggers in place. We have the right resources and capabilities in place. And now it's really just about getting down to work, making those essential partnerships between providers and payers.
Yep.
And another thing is leveraging something like the Trusted Exchange Framework and Common Agreement here in the U.S. That can really scale solutions with use cases like prior authorization, as we've seen treatment use cases in the past.
So we get some optimism there. Fantastic. All right, I've been speaking with Michael Gould. He's the AVP of Interoperability at ZeOmega. Mike, thanks for your time.
Thank you.